evening. Thank you, everyone, and welcome again to another week session of Health is the Ultimate Wealth, where every Saturday at between 5:30 and 6:30 p.m. we bring to you a relevant medical topic. Today, we are truly honored to have Dr. Kausik Sen over here with us. He's one of the senior neurologists over here at Medica Super Specialty Hospital, and he's going to talk about a condition which every single one of us has experienced at some time in our lives, headaches. And we're also going to discuss a little bit on what are the different types of headaches and the basics in the treatment of headaches, and when is a headache just a headache, and when और कब headache कुछ और हो सकता है, कुछ और sinister या कुछ और dangerous हो सकता है. तो as always, अगर आपके पास कुछ questions हैं, आप हमारे chat box में डाल दीजिए and we will answer those questions to the best of our abilities. But without any further ado, thank you so much everyone for coming, and I'm going to hand the session over to Dr. Kausik Sen. Dr. Sen, please.
Thank you, Dr. Aviral, for your kind introduction. Today, my topic is a very common topic, headache, and I will try to be as simple as possible, and I will try to tell when headache actually becomes a real headache. Headache is defined as a diffuse pain in various parts of the head when the head pain is not confined to the area of distribution of any particular nerve. It is among the most common pain problems encountered in our clinical practice. How to classify the headache? We usually classify headache under two broad headings. One is primary headache and one is secondary headache. What is a primary headache? Where headache is usually benign, it is recurrent, and it is associated with no organic disease. There are many types of primary headache, but to cut the discussion short and simple, there are three main types of primary headache: migraine, tension type headache, and cluster headache. And there are a host of secondary headaches which are caused by underlying organic disease, either of brain or in other parts of the human body. What are the important causes of acute secondary headache? Number one, headache associated with head trauma. Second is headache associated with vascular disorders like subarachnoid hemorrhage, acute ischemic or hemorrhagic stroke, temporal arteritis, unruptured vascular malformation. The third is headache associated with non-vascular intracranial disorder like idiopathic intracranial hypertension, any infection in the brain, and low cerebrospinal fluid pressure. Next comes the headache associated with substance abuse or withdrawal like cocaine, alcohol, etc. Next is headache associated with systemic infection. Everybody has some kind of infection or the other in some parts of their life. They may be bacterial, viral, tubercular, anything. Mostly viral and bacterial systemic infections are associated with headache. Headache associated with metabolic disorders like increased carbon dioxide level in the blood, low oxygen level in the blood, and low sugar level in the blood. Next comes the headache or facial pain associated with any problem in the cranium, neck, eyes, ear, nose, sinuses, in mouth or teeth. And next comes the cranial neuralgias. They are not true headache in real sense, but we keep cranial neuralgias under classification under secondary headaches. Now let us come to some clues to the bad headaches and those headaches which are not that bad. Number one, first of or worst headache of the life. A person complaining, बहुत ज़्यादा सिर दर्द हो रहा है, I am not able to stand that. This kind of headache is very suggestive of subarachnoid hemorrhage. Primary headache, which I have told earlier, can occur at any age, but most often beginning during childhood or between 20 to 50 years of age. Any onset of headache after 50 years is a red flag for a consideration of secondary headache disorder such as mass lesion or temporal arteritis or any other secondary pathology. If the patient routinely has headache, it is important to determine whether the current episode is typical. Is this headache like the one you usually have? We have to ask this question to the patient. Now, the symptoms of headache. We have to ask again in details to the patients coming to us in our OPD. What symptoms do you have before the headache starts? What symptom do you have during the headache? What symptoms do you having right now? A primary headache disorder such as cluster headache, it is one-sided headache with tearing from the eyes and blockage sensation in the nose, or migraine with aura, which have a scotoma, photophobia, phonophobia, nausea and vomiting. Any secondary headache disorder will have some neurological signs like stiffness, disorientation, rash, fever, eye pain, double vision, one-sided weakness, balance problem. They are suggestive of headache secondary to any problem in the central nervous system. Now, then we have to proceed and ask the onset of the headache, whether it starts gradually or suddenly. As I told before, headache of sudden and severe onset can be due to subarachnoid hemorrhage, acute ischemic or hemorrhagic stroke, posterior fossa mass lesions, and vascular malformations. And location and radiation of the pain. The cluster headaches are strictly one-sided. Tension type headaches are usually band-like and bilateral with posterior predominant localization. Migraines generally begin one-sided but may progress to involve the entire head. Pain along the distribution of the temporal artery may suggest a temporal arteritis, especially in the elderly people, and pain along the distribution of the trigeminal nerve may be a sign of trigeminal neuralgia. When the patient comes with a complaint of eye pain, it may suggest acute glaucoma. Next, we have to ask the severity and quality of the pain. The tension type headache has a mild to moderate, pressing or tightening kind of a pain, holocranial or posterior predominant, often associated with insomnia and depression. Cluster headache, predominantly male sex, severe stabbing unilateral pain, alarm clock type of headache, each episode lasting from 30 minutes to 3 hours. And there are autonomic features present like salivation, lacrimation, red eyes, like this. Migrainous headache, it is moderate to severe throbbing kind of a pain, which lasts anything between 4 to 72 hours, usually one-sided, associated with nausea, vomiting, photophobia, and phonophobia. And then we have to ask the concurrent medical conditions. Is there any history of any infection in the brain? Is there any history of any tumor in the brain? Is there any history of aneurysm or artery venous malformation, or any history of systemic bacterial viral infection? Then we have to ask what are the medications the patients are on. Inquire about over-the-counter medications for headache, like non-steroidal anti-inflammatory drugs, caffeine-containing analgesics, ergots, and triptans. Medication overuse headache is a very important cause of headache we occur in day-to-day practice. Please do not take these medicines without consulting your doctors. Any other headache-promoting medicines like nicorandil, nitrates, sildenafil, and tadalafil. And then we have to ask a recent trauma or procedures. Inquire about head injury. Sorry for the interruption. Any lumbar puncture, tooth extraction, neurosurgical operations or procedures. If yes, you have to consult your doctor who has done the procedure first.
Sir, sorry to interrupt you, sir. Your video has hung. Dr. Sen, are you okay?
Yeah, I'm fine.
If you could just restart your video, sir, I think it's just hung a bit.
Yes, I have been told the IT.
It's working now.
Next step. Now, a very important question to the common people. If you are suffering from headache and your answer is yes in 4 out of 5 questions, then you can have a migrainous headache. So these 5 questions are: do you have frequent or intense headache? Does your headache last for more than 4 hours? Do you usually have nausea when you have headache? Does light or sound bother you when you have headache? And does headache limit your daily activity? If you have 4 questions positive out of 5, there is a high chance that you can have a migrainous headache. Now, there is a chart showing few common types of headaches from mild to very severe, like tension type headache, migraine, cluster headache, and sudden onset headache. Tension type is the most common, occurring around 70% of the people. The pain level is mild. The symptoms are dull pressure on both sides of the head. And it can be treated at home initially with the painkillers, aspirin or ibuprofen or similar group of drugs. Then comes the migraine, around 15% of the common headache patients, which has a moderate to severe pain. And there is a light and sound sensitivity, and it can be scheduled to a primary care appointment initially or to the general physician. And if they cannot manage, then the neurologist have an important role to play. Cluster headache, around 0.1% of the population, which is a very severe and intense pain with runny nose or eyes and tearing, then we have to call your neurologist or headache specialist. And sudden onsets are much more near, as I told before, worst headache of your life, sudden severe pain, dizziness, slurring of speech, and numbness. You don't for anybody, go to the emergency as soon as possible. Now let us come for few important migraine triggers. And all the patients and common people should have awareness of that. These are common migraine triggers like stress, lack of sleep or jet lag, hunger or dehydration, certain kinds of foods like cheese, excessive caffeine, chocolates, black cold drinks, Ajinomoto containing foods, food additives, alcohol, active and passive smoking, caffeine, medication overuse, smells of strong perfumes, lights and sounds, weather, female hormones, and excessive physical activity. Now, next, coming to the 7 steps to avoid your triggers. Very simple. Watch what you eat and drink. Eat regularly, curb caffeine, be careful with exercise, get regular shut-eye, nap or sleep, downsize your stress, keep up your energy. Next comes to the lifestyle modifications for headache and migraine. First, coming to the diet, trigger the elimination means eliminate the diet which triggers migraine. Do carefully, but don't over eliminate. There is a limit to everything. If you tell a young lady to remove cold drinks, chocolates, Chinese foods, nuts, possibly they will not listen. So we have to do it carefully. Exercise regular and moderate, and very good hydration is important. Next comes to the sleep. Regular sleep and wake times is important. Sleep at proper time for at least 6 to 8 hours at night, and address insomnia behaviorally rather than taking medications. Next comes relaxation and meditation, biofeedback, cognitive behavioral therapy supported by good evidence. The main key is to find out the option to which patient will adhere. I can tell hundreds of lifestyle modification, and if the patient doesn't adhere to any one of them, there is no point. Now coming to a very particular interesting kind of a headache, which we term as broadly alarm clock headache. A headache usually occurs during sleep, most often between 1 a.m. at night to 3 a.m. at night, and rarely during the daytime nap. Usually occurs daily, almost daily in the same time. Cluster headache and hypnic headache are two common causes of alarm clock headache. But we neurologists need to rule out other causes like obstructive sleep apnea, nighttime high blood pressure rise or low blood sugar, nighttime convulsion, inflammation in an artery in your head, what we call as temporal arteritis, and brain tumor. Now coming to the point, when I feel worried for the patient, headache with signs of systemic illness, like a patient having headache with fever, stiff neck, rash, which indicates meningitis. Headache with focal neurologic signs like there is a sign for mass lesion, stroke, vasculitis, or vascular malformation. If there is papilledema in the eyes, is suggestive of meningitis, mass lesion, or idiopathic intracranial hypertension. And if the patient complains of headache after a head injury, there is a possibility of intracerebral hemorrhage, subdural hemorrhage, epidural hemorrhage, and post-traumatic headache. Next comes headache beginning after 15 years of age is suggestive of mass lesion, temporal arteritis. We have to rule out these things. Sudden onset severe headache, I'm repeatedly highlighting this, is very much suggestive of subarachnoid hemorrhage, hemorrhage into a tumor, arteriovenous malformation rupture, and a posterior fossa mass lesion. Headache which is increasing in frequency and severity day by day is suggestive of space occupying lesion, subdural hematoma, and medication overuse. New onset headache in patients with risk factor for HIV infection or cancer may be a clue for brain abscess, meningitis, metastasis, and infective granulomas. Now coming to a very important point, indication of referral to the neurologist. Headache is many of the times seen by the primary care physician or general physicians or house physicians. But there are certain conditions where the patient needs to be referred to the neurologist. They are like physician has an inadequate level of comfort in diagnosing or treating patient headache. Second, patient's request for referral. Next is patient does not respond to the treatment it is given. Patient's condition continues to worsen. Physician is unable to classify patient's headache according to the diagnostic criteria for primary or secondary headache disorder. An uncommon headache like trigeminal autonomic cephalgia, new daily paroxysmal headache, medication overuse headache, or the patient has intractable or daily headaches. And now coming to what we do at Medica for these headache patients. We have a specialized headache clinic every Thursday. All headache patients are extensively worked up with proper history taking, clinical examination and investigation. And if needed, headache patients are admitted for better management. Thank you everybody for your kind attention.
Thank you so much, sir. I think that we can all say that is a very, very extensive talk to the basics of, understanding headaches and how to diagnose and how to treat them. So I want to ask, sir, one of the very common conditions that we have here in India is hypertension. So how does hypertension connect to headaches, and at what level do we does hypertension start to cause headaches?
Usually anything blood pressure above 160 systolic can produce hypertension induced headache, but higher the blood pressure, more chance of a severity in the headache. Many of the time, the hypertension neurally triggers a kind of reversible cerebral vasospasm. The blood supply of the headache triggering zone is affected. The brain doesn't get proper nutrition, blood supply, glucose for a reversible period of time, and that somehow triggers the headache sensitive areas in the brain, producing headache. This is one mechanism. Second, hypertensive headache sometimes can produce a neurological condition causes stress, posterior reversible encephalopathy syndrome, which is well known to produce headache.
Excellent, sir. Thank you. So, our audience, please, if you have any questions, please do set it up in the chat window or in the Q&A window, and we'll do our best to try to get them answered. Sir brought up a lot of interesting points. So you were talking about cluster headaches, correct, sir? So,
Yes.
and cluster headaches, you said, happened around 1% or 2% of the population. So the cluster is that the symptoms happen suddenly over a short period of time and then go away. What is it exactly then?
The name suffice, it's a cluster. Either it can be episodic cluster or it's a chronic cluster. Episodic cluster is very, very common. It is more common in the 60 plus age group in the male population, but younger patients do suffer. They occur in cluster. Few days to months, they will have an intense headache, and suddenly the headache will disappear. They will be absolutely free 1 month, 2 months, 3 months, even 1 to 2 years. Again, that headache will come back. That's why we call it as a cluster headache. And this is a classically episodic cluster headache. And very few unfortunate patients have a very frequent cluster. We call it as a chronic cluster headache.
Okay, sir. Thank you. So just for our audience, suppose they are having a bad headache. What is a good empirical treatment, or what's a good initial starting treatment for the management of headache? You know, there are so many people. Some people take Decold total, some people take migraine medicine. But if somebody has a new onset headache and they never had a headache problem before, and they don't have any of the alarm symptoms that you mentioned, what's the easiest, or the easiest treatment they can start to get some relief?
I will suggest the easiest and safest treatment to be paracetamol. The dose anything ranges between 650 milligram to 1 gram. The safest and reasonably effective in most of the headaches.
Okay.
I will first try to tell them to avoid the non-steroidal anti-inflammatory drug, because many of the time headache might have some sorts of viral infection with maybe a low platelet count, or patients might have maybe we don't even know some kinds of CNS bleed, maybe small, and they don't tend to have classical paralysis. And if you give NSAIDs to this patient without documentation, they might worsen the bleed or might worsen the platelet count. So paracetamol doesn't do anything of this. At least it is a good drug to begin with.
Okay, sir. Perfect. And you're right, a lot of the viral fevers tend to cause headaches. In fact, dengue, which we are having a current epidemic ongoing, is associated with a retroorbital headache. A lot of patients ask me, is this dangerous to the eye? What are your thoughts on this, sir?
No, the retroorbital headache in dengue is nothing to do with the eye. Eye will not primarily be affected. It is just a localization of the dengue headache.
Okay, perfect, sir. And what about sinusitis, sir? A lot of people, like you mentioned, surgical procedures, but sinusitis tends to cause a headache. How do you differentiate the sinusitis headache from, say, maybe what a migraine headache is like, sir?
First, I will try to say that sinus-related headache is comparatively less common than migraine. What we see in clinical practice, the sinusitis headache patients, first of all, should have a history of sinusitis, either present or past, and their paranasal sinuses are tended on palpation in general. If we press the sinuses, they will tell, large darad ho raha hai. And they are predominantly frontal and in and around the distribution of the paranasal sinuses, not like in the proper headache zone of the migraine.
Okay, perfect, sir. And what about ear pain? What does ear pain, and when does ear pain become headache, and when should you be concerned about that?
Many of the headaches like migraine and cluster headaches can have a non-specific ear pain, but there is certain called as otalgias, which mimics the headache. Like there are a lot of neuralgia pains like glossopharyngeal neuralgias, Sluder's neuralgia, enlarged styloid process. These are all can produce otalgia and headache. So we have to be careful. And if the person categorically complains of ear pain, we have to investigate in and around the ear zone.
So I think we have had a very long and comprehensive talk. My final question, after which I promise the audience I let them free. So have you noticed, with now the onset of a lot of people using mobile phones and not laptops, iPads, they are constantly bending forward and squinting and looking at these small screens and typing away. They have a poor posture, they're bending down. Now, does this poor posture and constant typing and looking at close objects, has you noticed an increase in any certain types of headaches related to this, sir?
Absolutely. We have witnessed a lot of headache, and there are multiple reasons. This first is refractive error associated with continuous mobile and laptop use. Second is the postural changes. They have a cervical spondylitis and bent neck quite early in their life, producing cervicogenic headache. And lot of patients have an accommodation problem, and lack of accommodation and difficult and improper accommodation per se will produce headache. So there are multiple mechanisms which is producing headache due to the problem you have just told us.
We have one question, sir.
Yes.
Caffeine and migraine, it is something I could never understand. Is it a common trigger, and how does it help in treatment? I think this is interesting because for some people, caffeine seems to help their migraines, and for some people, caffeine seems to trigger their migraines. Sir, what are your thoughts on this?
You just told the answer in your last line. That's very important. The patients who are benefited from caffeine, they can take caffeine. There are some patients with caffeine will create extreme harm. They have to avoid. They have to know their triggers. And even those who are benefited from caffeine should be at moderate dose. It should not be at high dose or लगातार कॉफी पीना ठीक नहीं है.
So I think you bring up an important point, sir. What is high dose of caffeine, or what's a high dose of coffee, beyond which you're running risk of headaches and other side effects of caffeine?
Those who are caffeine sensitive, even 1 cup of coffee is bad for them. Those who are not, probably we might allow 2 to 3 cups of coffee at best per day. That can be allowed, maybe at least 2 to 3 cups. But anything more than that may be a little bad for the migraine patients.
Okay, perfect. I think, sir, thank you so much. I think you've given very comprehensive answers. Thank you so much to our audience for listening in. We are aware it's a Saturday evening for you, and I'm sure you all have plans. Once again, thank you so much. This is Health is the Ultimate Wealth. We are present every Saturday, 5:30 p.m. onwards for the latest health topic. Dr. Kausik Sen, thank you so much for your presentation. To our audience, thank you so much for joining us. And to our wonderful IT team, as always, for hosting the meeting and broadcasting it on Facebook Live as well. We look forward to meeting you again next Saturday, 5:30 p.m. Thank you. Have a good weekend and happy Pujo.
Thank you.
Thank you, sir.
Thank you.